I'm Dr. John Hunter. I'm a colorectal surgeon here, but I'm also trained in general surgery and minimally invasive surgery. Minimally invasive surgery is just any surgery that we can do in the abdomen or chest cavity or wherever without a big incision. So we're going to talk about hernia repair and how that relates to the surgical robot. And we'll talk a little bit about what the robot is, what hernias are. This is sort of an outline for what I'm going to talk to you guys for the next 15 minutes about. We're going to talk about what is a hernia, how do we fix them, what is robotic surgery, and what are the benefits of robotic surgery. As I said, I'm a colon and rectal surgeon, but I do robotic surgery as well as Dr. Richards. He does robotic surgery as well, and we both do hernia repairs. Robotic hernia repair is sort of new in the last 3 or 4 years, but it's been the most quickly adopted surgery on the robotic platform. And so it's really taken off over the last few years from a general surgery standpoint. So all different kind of surgeons use the robot. Gynecologists and urologists were the first to use it. Colorectal surgeons use it, heart surgeons use it, chest surgeons use it, and general surgeons are the more recent, and their adoption has been very, very quick and I think very helpful for the patient. So what is a hernia? So this is sort of a picture of the abdominal wall, and our abdominal wall is made up of muscle and connective tissue, and it sort of is a nice, it packages all of our organs inside. And so this is, it's multiple layers, as you can see through the cutout there. And sometimes weak points exist in this abdominal wall, and that's where we get hernias. And this depicts various kinds of hernias, but basically we're going to be talking about 2 kinds of hernias. Abdominal wall, which can be an incisional hernia where you may have previously had surgery and now you've developed a bulge there. Ventral is just kind of anywhere, that's a kind of catch-all term. Or umbilical, that's a natural weakness that everybody has in their abdominal wall, and some people will go on to develop a hernia there. The other common place we see hernias, especially in males, is inguinal hernias or groin hernias. And so we're going to be talking about those kind of interchangeably, abdominal wall hernias and inguinal hernias. And so again, this is just another depiction of the abdominal wall and the various layers of muscle and connective tissue. And how do these hernias show up? Now, you don't have to read all this stuff. I just wanted to use these folks' pictures. But you can see in this middle section, we've kind of cut the belly in half, and you can see the different layers there in that middle picture. I can use this as a pointer. And what can happen is there can be a weakness where organs can kind of slip through and cause that bulge that you may have heard of. And actually, when they get, sometimes those organs can get stuck in that hernia and become what we call a strangulated hernia. And that's actually an emergency where we need to get in there quickly and get that bowel out because it can go on to die or perforate and make you really sick. So all this is just showing that your abdominal wall is holding everything in, but it can develop weak points where things can try to push through, okay? And that's where you can get into trouble. Here's another depiction of that. This is kind of a side view, and you can see some bowel poking through there, and you can see a little bulge here. This is the umbilical. And epigastric, all that means is just up higher by the stomach. It doesn't have to be bowel in here. It can be just normal fat that is inside the abdominal cavity that can poke through. That's not as dangerous, but it can still be very painful, and still, if it's painful, needs to be fixed.
What is the difference between an indirect and a direct?
That's a good question. So down in the, he's pointing over here to the right side. This is an inguinal hernia, and there are several, in this area of the body, there are several natural areas that can be weak, okay? And the direct and indirect, it refers to specific areas within that, the groin that can be weak. So we talk about indirect and direct hernias. The direct hernia is just a weakness in the abdominal wall itself. An indirect hernia is actually one that works through the same canal that the spermatic cord goes down to the testicles. So that's an actual normal hole in the abdominal wall that it's supposed to be there, but it can also enlarge and intestine can work its way down there. So when we repair these, we try to cover up the direct and the indirect space to prevent hernias from recurring in either of those spaces. So that's a really good question. So what causes a hernia? So here I've listed some causes. Anything that's causing chronic pressure on the abdominal wall, if you can imagine over time, as a kid when you were running in and out of the house in the summertime and pushing on that screen door instead of the handle. Throughout the summer, it would just get weaker and weaker, right, until it's bulging out. So that's the same idea with a hernia. Over time, years and years, with chronic pressure, that abdominal wall weakens. And if you've got a natural weak spot like your belly button or your inguinal region, or if you've had a surgery and you've got a natural weak spot from a previous incision, those are going to eventually become a hernia, possibly. So heavy lifting, we see it. We see groin hernias in professional weightlifters, people that do a lot of sports. If you have bad constipation or you have trouble urinating, you may strain a lot to do those things, and that can increase your pressure in your abdominal cavity. Obesity is a risk factor. People with a chronic cough, every time they cough, they increase the abdominal pressure. That's another stressor. Pregnancy, obviously, it creates a lot of pressure on the abdominal wall, and we see women with umbilical hernias that develop during their pregnancy. And we talked about a pre-existing weak spot, so previous surgery, or like I said, congenital, like your belly button or the groin. Those can all lead to hernias developing. What are risk factors for developing a hernia? Well, these have been studied, and some that have come out as being a male, unfortunately, you're a little bit higher risk, especially in the inguinal region. Females can, however, develop inguinal hernias as well. Age, the older you are, the longer you've had to put pressure on your abdominal wall, and so the more likely you are to have developed a hernia. We mentioned chronic cough, so smokers are at increased risk. Smoking also weakens, will naturally weaken the tissue in the abdominal wall and make you more susceptible as well. We mentioned chronic constipation, pregnancy, and anybody who's had a previous hernia repair, we can never get it back to 100%, and so that strength of the abdominal wall is always a little bit less, and so that actually puts you at a higher risk for having a recurrent hernia, okay? Stop me at any time if you have any questions. All right, this is an open...
Can a screen help?
Yes, and we're going to talk about that. Yes, ma'am. So what are some of the symptoms that we notice? So the obvious one is a bulge, right? So you notice this sort of lump that may come and go. It may worsen with coughing or straining, and over time that may become painful, and you may notice some burning or aching at that bulge. It intensifies with straining. If you ever get to the point, we mentioned the bowel can slip through there and get stuck. If you ever got to that point, you may notice that you have, or somebody has nausea and vomiting and can't keep food down because food can't move all the way through, it gets stuck. That's an emergency that needs to be fixed. Again, this is another kind of progression of hernia. We see the abdominal wall with this defect, and that's some fat poking through, but over time it can enlarge and bowel can get through there, and then that bowel can get stuck and actually lose its blood supply because it's squeezed through a tight hole, and then it becomes strangulated. So how do we fix these hernias? Well, sometimes we don't have to. Some people have small little belly button hernias that we'll notice on exam, or they may have noticed, and it doesn't really bother them, and it's pretty small, and we tell them, let's just try to avoid things that can make this worse, but if it's not bothering you and you don't want it fixed, you don't have to have it fixed. But sometimes people do develop symptoms, and we look at fixing those. So there's a native tissue repair, meaning we just go in there and close that hole. And that can sometimes be done with small hernias where we don't put any screen door mesh in, but we just close the hole. And that's called a herniorrhaphy. But the mainstay of repairs is the mesh repair, or herniaplasty. And what that involves is putting a piece of synthetic or not native tissue, but biologic tissue in as a reinforcing layer to give strength and plug up that hole. So there are two different kind of meshes, and I'm not going to get into this in detail, but there's mesh that's natural tissue that's extracted from like the heart lining of cows or pigs or pig skin. They take all the proteins out of it, so it's just the collagen, that's the strength layer, and then we're able to put that in. The more common mesh that's used is synthetic mesh, and there's all different kinds. There's all different kind of companies that make them, and those are a little bit more durable, but they do carry a small risk of infection, and so we have to take that into account when we're deciding what kind of meshes to use. And these repairs can be done in three basic ways. So open repair, the traditional, we make an incision over the hernia, close it up, put a piece of mesh in. There's laparoscopic, and that's robotic, and that's kind of what we're going to talk about today. So this is just a drawing of the open technique for an inguinal inguinal or a groin hernia. And you can see over in this picture here, they've made an incision over the groin. This little bulge here is the hernia, and they've pushed that back in, and they'll close some of these tissues where that hernia bulged through, and then we'll lay this piece of mesh in here, and this is actually the spermatic cord going through that canal that it's supposed to go through. But you can see all the other areas are plugged up by that mesh so nothing can push through there again. And then we close all those layers up, and that mesh lives in there. And it incorporates into that tissue and gives it some extra strength. So hopefully over time, this hernia can't recur, okay? This is an abdominal wall hernia. So this is, your bulge at your belly button, or maybe you've had a previous surgery where they had to make an incision and you developed a hernia. You can see we make a big incision here, reduce the hernia, and we sew this piece of mesh in. And that mesh acts as a reinforcement or a strength layer and incorporates into that tissue and hopefully gives you a stronger abdominal wall so you don't go and redevelop that hernia. But note the size of the incision here. It's not trivial, right? It's fairly large. So the open technique is tried and true. It's what we've been doing since the beginning days of surgery, but it does require a relatively large incision depending on the size of the hernia. And with that comes incisional pain. With that comes wound infection risk. The larger the incision, the more likely you are to develop a wound infection. They usually require a hospital stay because they're painful, and if we did some work on your intestines, you may have to stay in the hospital for a few days to make sure your intestines start working. But sometimes this is the only option. Sometimes in big complex hernias, this may be the only option you have. But fortunately, these days, most of these can be approached with a more minimally invasive technique, and I'll explain those. So this is a quick depiction of the laparoscopic technique, and basically laparoscopic surgery, you've heard of laparoscopic gallbladder removal or appendix removal, and all that means is we're putting small cameras and what we call trocars or ports through small 5 or 8 millimeter incisions, and that blows up air into the abdominal cavity, and that gives us space to work and put instruments in and work with these long instruments to do whatever surgery we're doing in the abdominal cavity. And the advantage there is you don't have a big incision where you're opened up. You have 3 or 4 smaller 5 millimeter incisions. In a laparoscopic hernia repair, we put ports in and we put mesh to cover up the hole, just like we mentioned in the other one. And I've got another depiction of that, a little bit better depiction here. Again, this is somebody laying flat, and this is that bulge that they have, and we go in there with our laparoscopic instruments and lay a piece of mesh in there. The thing with laparoscopic surgery is it's very difficult to close this hole, just by way of how laparoscopic surgery works with instruments that are straight. They don't bend on the inside. They're just straight. It's like working kind of with chopsticks. And so it's very difficult to close this hole, and so the most common way this is done is just put a piece of that screen door up there, tack it into place, and you're done. So you cover up that hole so things can't bulge through it, but you may still have a little bit of a residual bulge after that. The other thing to note here is how these, what we call transfascial sutures, and basically these are sutures to keep that mesh in place, but they go through the entire abdominal wall, okay? And they're tacked into place, and we actually have noticed that patients have quite a bit of pain from that for several days. If you can imagine a tight suture being placed across the entire thickness of your abdominal wall, that can hurt. And so we oftentimes have to admit these patients for a day or two just for pain control, because this technique, although it does have much smaller incisions in the open technique, it still hurts from those transfascial sutures. However, the laparoscopic technique has a great advantage. Much smaller incisions. Smaller incisions mean less chance of a wound infection, less pain than a big incision, although you do have some pain from that transfascial technique. There has been proven in studies that faster return to normal activity. So you bounce back from this a lot quicker than you do from a big open repair, okay? You do often need a day or two in the hospital to get over that acute pain and help with that pain control. And the other thing I've highlighted down here is the primary defect, or that initial hole that you developed, that hernia, is actually usually not closed. Sometimes we're able to close it a little bit, but usually it's left open and you just have a piece of mesh there. So what is the surgical robot, and why are we here talking about this, and what does it help with? So I'm going to introduce the robot to you a little bit. Has anybody here seen any videos or pictures of the surgical robot? Just raise your hand, a few of y'all. Okay, good. Dr. Richards has. Thank goodness. So this is the surgical robot. This is made by a company called Intuitive Surgical. They're a company out in California, and they're really the only surgical robot in practice right now. There are some coming down the line, but these guys have been around for, I don't know, 15 years developing this thing, improving it, and this is the latest iteration. It's called the Da Vinci Xi robot, and it consists of these three parts that are in the operating room. We're going to go through those real quick. So this is the surgeon's console, and basically, I'll back up. What we do is this big thing over here with the robotic arms is actually attached to the patient, and those little ports that we put in the abdominal wall, we put instruments through those ports, and the robot holds those instruments for us. Now, the term robot is a little bit of a misnomer because robot means the machine is thinking for itself and making decisions. That is not what this is doing. We have complete control. At no point is the robot moving without us telling it exactly how to move with our hands, okay? So we call it a robot because everybody knows what that is, but it's not technically a robot. This middle part is kind of the brains behind it. It has a lot of the different computer parts and things that the robot needs to work. And then this over here is the surgeon's console that's sat off in the corner of the room, where once we get the robot connected to the patient, we go and sit and start operating, okay?
Now, didn't USA just get one of these?
We did. We got 2 of these a year ago. So we've had them just about a year, almost.
What are you talking about money-wise? What does one of those cost about?
That I don't know. Maybe Dr. Richards knows.
So, we have the intuitive rep here. Do you want to say anything about that? I would give it a 3. They're about $1.5 million.
Yeah.
But they're worth it.
Yeah.
And we'll show why they're worth it.
It depends. Her question was, does surgery cost more on that? And it depends on how your hospital is able to implement it, but usually we can get it to where this type of surgery and laparoscopic surgery can run about the same cost. It just depends on volume and that kind of thing. So this is the part where the surgeon sits, and if you look here, and I don't have a picture of it, I'm sorry, but you sit down and your fingers go in these 2 little devices here, and your head rests here, and you look into this viewport, okay? And the advantage here is it gives you very high definition, 3-dimensional view. So that camera that goes into the patient's abdomen is actually 2 cameras, a left and a right, and so it sends a left and right image to your eye, and you actually see 3D inside the patient's body, which is very, very helpful. In a minute, I'll show you how the controls replicate your full wristed range of motion, and it attenuates it down to small movements into the patient's body. So the surgeon's hands movements are translated into real time into precise surgical instrument movement. And we can scale that down to very precise movements to help you do really delicate surgery. And there's foot pedals you see down there at the bottom that control various parts of the robot. I mentioned this is called the vision system. It kind of has the brains of everything. We won't go into that very much, but everything's hooked up to that. And then this is the patient side cart. So this is 4 arms, and we put a camera in one and then 3 other instruments in the other. And I pulled these slides from another more technical talk, but basically those arms are docked to the patient, and then we have full control, and those arms during the case are moving around all kind of crazy like, and because they're translating our movements at the console to movements inside the patient's abdomen, okay? So this is kind of another depiction of those arms from the side on the right here, and these are just kind of a sample of all the different kind of instruments we can put through there. These are all different kind of graspers, these are clips, all different these are needle drivers. So you can see and the list goes on and on. There are lots and lots of different very specialized tools that the robot can use to perform an operation. So it's really quite impressive to see what can be taken from a normal handheld tool down to a very small size and then be controlled by you 20 feet away with the help of this robot. So what are the advantages in the operating room? Well, I mentioned the high definition viewing, the 3D imaging. It's very magnified. It's very clear, crystal clear view. Just anecdotally, I can see when I'm doing rectal operations, I can see nerves that I couldn't see before laparoscopically or with my own eyes. and that's helpful. That's helpful for the patient and me as well. It's easier to get into tight areas that are hard to get to open or even laparoscopically. I mentioned surgeon ergonomics. It's much more comfortable for us to operate on the robot. I'm sitting down, I'm comfortable, I'm not leaning over. I haven't developed the surgeon buffalo hump yet, and I hope not to, because I hope to just operate on the robot. And there's been studies that shown that surgeons' careers may even be lengthened because they're not getting these repetitive stress injuries that laparoscopic and open surgery may be causing. And so, and again, I mentioned how it replicates our natural hand movements in the patient's abdominal cavity. So this is kind of a depiction of what that means. So, you can move your hand all in these different degrees of motion, and the robot can translate that to the exact same thing. So laparoscopic instruments, like I said, are just straight sticks and graspers. They can't do this, okay? They can just do this. But this tool will allow us to move our wrist around inside the patient, which affords a huge advantage, especially in hernia repair, which I'll talk about here in a second. So I wanted to show you a couple of videos just very quickly. Let's see, how do I do that tab? I think it's Alt-Tab, yeah. If y'all have already eaten, which maybe we should have shown these before lunch, but we're going to look at just a few videos that are kind of neat to see this thing in action, just so you can kind of get an idea. This is suturing a grape, which isn't too upsetting. But you can, this shows just the very precise movements that this instrument, this robot, can replicate and allow us to do all this inside the abdominal cavity through very, very small incisions. So you know how delicate a grape is, but this is able to handle that without ripping and tearing. They bring some scissors in there to cut the suture. And that's actually all done through one port, through what they call their single site. And I'm just going to step through these videos kind of quickly. I'm just going to show you a little bit, but this is an open technique for a belly button hernia repair, okay? So we're going to make an incision and then put some mesh in, okay? I sped it up too. We're not going to watch the whole thing, but so there's an incision made at the belly button. And I'm going to jump forward, and they're kind of working their way down to get to this hernia. A little bit more here. That's some of the hernia fat we talked about sticking through there. And they're going to measure the defect or the hole. And then in a minute here, I'm going to show you, they're checking to make sure nothing else is stuck under there. And there's your mesh. They're going to bring that in and put that inside. And this actually is a pretty small incision, right? I mean, it's only a couple of centimeters, and it's a very, very small hernia. And they're sewing the mesh in, and I'm going to skip through some of that. And then they're going to recreate the belly button there. You got to tack it back down so it looks like a belly button. And then they're closing it up, okay? So that's the open technique. So let's see what that looks like on the robot, okay? So instead of making that incision, we're going to put 3 little tiny incisions about that big. This is this guy, and this is his. These are all on YouTube, so you can go find them. So that's the hole. There's some intestinal fat stuck up there. And you can see how these instruments allow us to do normal hand motions inside the belly. And this is a totally different technique from that open. They're going to make a little space in here, get to that hernia. I'm going to jump forward a little bit, sorry. So I'm going to back up here. So there they've gotten to the hernia, and they're working on getting that fat that got stuck in there down. In a minute you'll see that hole that shouldn't be there, okay? So that's what was causing that patient all that discomfort. And now you'll be able to appreciate that hole a little bit more.
Are those larger instruments though than the laparoscopic?
They're about the same size. They're about the same size. So they're looking for other hernias, and now they're going to And this is something we couldn't really do very easily with laparoscopic surgery, is close this with suture. It's very hard to, with straight chopstick type instruments, to close a hole on the ceiling, okay? And so the robot with the wristed instruments allows us to do that. And you can see he's putting some suture in. I'm going to close that up. The bedside assistant, either the scrub nurse, or here at South Alabama we have residents learning, and when they get started on the robot they have to do a certain number of bedside assists before they get on the console. So usually with the residents scrubbed in, they'll pass off some of that stuff too. But we have a surgical robot team that specializes in robotic surgery, so they're all well trained in passing off instruments safely and passing sutures and that kind of thing. So here you can see they're laying that mesh in. And the nice thing about this is you'll notice there aren't any of those transfascial sutures we talked about, okay? Because we're able to get in this special space outside the abdominal wall or outside the abdominal cavity, we can just tuck it in there, it'll stick in there, and then we close this flap. And the other advantage here I didn't talk about earlier is that there's no mesh on the inside of the abdominal cavity. You hear these horror stories about mesh and bowel eroding into mesh and causing really bad problems. The bowel can't get to that mesh anymore because it's tucked in that pocket, okay? And so that's another big advantage of this technique. We talked about groin hernias. I'm going to show you just real quickly what that looks like. Big incision, working getting that hernia out. You can see a lot of the section there. They've got the spermatic cord, and they're taking some fat off of that, and that's the hernia there poking through. They're going to get that all reduced down. I'll jump through that real fast. Here we're getting our mesh ready, and they're going to get that mesh placed in there carefully. And then sew it in. They're going to tack it to the various ligaments and bones around that area to keep it in place. Okay. And then still a relatively small incision, but it's not trivial, and it does hurt. And there they're closing up the layers, and there they're closing the incision. So with the robotic approach to that, we can get away, and this doesn't show the incisions, but this shows those two hernias from the inside. We looked at it from the outside. That's what they look like from the inside. And so here's this surgeon making that pocket like we showed earlier and pulling that hernia down. And the neat thing about this is through the same 3 ports, so we put 1, 2, 3 ports in, he can fix hernias on both sides. So a lot of times people come in with a left and a right, and they have to have 2 separate big incisions to fix those. We can fix both of these through the same incision at the same time. And that's what he's going to do here. There he's developed a pocket on the right. Now he's going to develop a pocket on the left. And I'll jump forward a little bit here. And it doesn't go this fast. I just sped it up artificially. It is a nice quick surgery, but it's not that fast. You can see he's unrolling his mesh in that pocket to cover up those holes. And we cover the direct space and the indirect space and a third space in that area called the femoral space to prevent hernias from recurring in that area. And there's no tacking, and then you just close up that pocket. And again, that mesh is not in the abdominal cavity. It's outside, so no bowel can come in contact with that and erode. Okay? And this is done through 3 8-millimeter incisions. Okay? And I'll show you those here in a second. This is another quick, this is kind of the future. This is actually out now. This is all through, what is it, a 2 centimeter port? Will? Or 1.5 or 2 centimeter? So 2 centimeter incision, you get a camera and 3 instruments, and you can do quite a bit of surgery through that tiny little incision. So this is sort of the next step coming down the line with the robot. I just thought that was a neat video. So what are the advantages of the robot technique we've shown? So small incisions like laparoscopic surgery, so lower risk of wound infection, less pain. We are finding here at our experience with this technique is that our patients are having less pain compared to the laparoscopic technique. And I think a lot of that has to do with we're not having to put those transfascial sutures in, those ones that cross the entire abdominal wall to hold that mesh in. So with that, you get quicker return to normal activity, shorter hospital stay. Oftentimes our patients will go home the same day, so it's an outpatient procedure. And the big thing I think is important here is the primary defect is easily able to be closed, okay? So you not only do you get that piece of mesh in there, but you get a closure of that defect as well. This is kind of a comparison of incision. So the green represents the hernia. For an open repair, you know, we'd have this big incision down the middle. For the laparoscopic repair, you have these 3 tiny incisions, but you also have the yellow represents those transfascial sutures. And oftentimes there can be 8, 10, 12 of those, okay? And those aren't trivial. With the robotic repair, it's just simply these 3 8mm incisions, okay? With the inguinal hernia, so bilateral inguinal hernia, that's 2 incisions in the groin. With the laparoscopic, 3 little incisions here, robotic, 3 little incisions here. These techniques are similar. I would say the robotic technique, and any of the residents here can agree, the laparoscopic technique is a lot harder to master than the robotic technique. This, I think, is faster and easier to learn. And so that's what I prefer this over the laparoscopic technique.
Now, the ports where you put the instruments in, do you close them up anyway?
Yes, sir. We close them up with sutures underneath the skin. They dissolve on their own, nothing to get removed.
Okay.
Yes, sir.
I've had 2 laparoscopic surgeries.
Yeah, they're closed up the same way as a laparoscopic surgery. Yes, sir. So what are the patient's benefits to this robotic repair? So we talked about decreased incision side, less pain, decreased hospital stay, decreased infection risk because you have a smaller incision, quicker return to normal activity. And what really hasn't been bared out is, does this technique result in decreased recurrence? And I think it does, but we don't have solid data for that. But there's data that points that way. And so I think with all these benefits, I think it's definitely a good tool to have, a good option to have for the community for these repairs. So that's all I have. What other further questions? Dr. Richards is going to get up here and talk as well.
If there's fat coming through the hole, is that always removed rather than stuffed back in?
It depends. It depends on the condition of the fat. Usually we'll take it out just because it's not in great shape. The blood supply is not good. We'll just go ahead and remove it. So it's not something that can try to push back through. But like bowel that's stuck through there, we don't have to remove the bowel unless it's sick.
How about age? Is that a major factor? I'm getting older, but I have one I need to get repaired.
No, you know, it's a bunch of different factors that all add up. So, you know, age is just because you're turning, 70 or 80 doesn't mean you're going to get a hernia. Now, if you're smoking and coughing all the time and very obese and had other risk factors, that's all going to combine. But it doesn't necessarily mean that you're going to get a hernia.
Is USA the only place you can get the robotic surgery?
No, ma'am. There are other institutions around here that are practicing on the robot. Yes, ma'am.
Robotic surgery primarily for abdominal, or they use it for heart surgery, brain surgery?
It's used all over the place. So abdominal surgery is probably the biggest area, but closely behind is thoracic surgery, so chest cavity surgery, lung surgery. It is used on the heart. It's also used in throat surgery as well. What am I missing? I don't know. I think that kind of. And orthopedic robots as well. Spine, yes, sir. Don't think so. Investigational? Not yet. All right.
Great job, John. So, my name is Dr. Bill Richards. I'm the chair of surgery. I came from Vanderbilt, where I was the chief of laparoscopic surgery. And I can tell you that one of the reasons I recruited John to come here to the University of South Alabama was that he was not only an excellently trained colorectal surgeon, but he was trained in the robot. And we knew that we had to develop a robotic program. So John has done an outstanding job getting our residents up to speed, and more importantly, getting me up to speed to be able to accomplish, robotic surgery. Now, I have been amazed. I've been a practicing surgeon for a little more than 30 years. This is revolutionary. It's absolutely revolutionary. Because when I started doing hernia repairs, we're talking about patients staying in the hospital 7, 8 days. An inguinal hernia repair was still an overnight stay, okay? And the patients would go home, sort of hunched over for weeks in excruciating pain, okay? And we had a high recurrence rate and lots of complications, I can tell you. The laparoscopic revolution revolutionized surgery. Minimally invasive laparoscopic cholecystectomy was revolutionary. And a lot of things we do now are done as outpatients, and we do amazing things with our laparoscopic colon resections and everything else. But the laparoscopic incisional hernia repair was still not great. And we saw a lot of patients that still had a lot of pain and discomfort. We started doing the robotic surgery, and I saw amazing results. So I know you don't believe me. So I thought, I've seen patients in clinic yesterday, and I'd like to ask Mr. Philip Bach to come up here. Philip is one of my patients. And I saw him in clinic yesterday, where he was 10 days post-op. So can we give Philip the microphone so he can be heard?
Yes, sir. The one I just gave you. I'm sorry to make this more complicated than it really should be, but
Should you get the TV mic here too?
So we're the wiring Philip up. What I'm going to ask him, first, I'm just going to ask him, what was it like having a hernia before the first time that I met you? Just tell us your history and, what you were going through.
So June 24th, I believe it was, of 2017, I had I think it was colon resection or something like that. I had a long incision that was made here. It was emergency surgery. I had gone septic, stuff like that. We fast forwarded up to almost a little over a month ago when I first met Dr. Richards. I had developed a hernia, a nice little bulge right here. At that point in time, the hernia itself, it was extremely painful. There wasn't too much work I could do around the house. We had about 2 acres of property, so yard chores were limited. I couldn't even sit on my living room couch without my wife having to come and help me back up. I had lost pretty much all abdominal function as far as core activity. It was extremely painful, and that was a very hard pill for me to swallow. I'm very active. I love being outdoors. And that was towards the end, before Dr. Richards fixed the hernia for me. It didn't initially start like that. When I got the hernia, it was a little bit of pain. I was like, oh, that looks kind of weird. Why is it bulging like that? But the pain progressively got worse. From, I think it was about December of 2017 up until, like I said, about a month ago when I first saw Dr. Richards, is about how long we watched that hernia continue to kind of push itself out and grow more in pain. It was extremely painful though. I can tell you this, I was on painkillers, narcotics, tramadol, Percocets and stuff like that, going all the way up to my appointment with Dr. Richards, where I was taking those daily. And to the point and for such a prolonged period of time that they really didn't work anymore.
Tell
So
us
that was
about
part
the
of it.
day of surgery.
So the day of surgery, it was very quick. Had an unfortunate but yet blessed experience with medical. I've had some medical issues in the past. Fell in love with USA Medical. That's where my wife and I chose to come to have this hernia repaired. So we were optimistic. This was the first time in several past surgeries where we were actually in control of the surgery, saying we wanted to get something fixed versus it being an emergency. It felt nice. We came in, we got received in, very warm and welcome, got right in, had the surgery. I couldn't tell you how long it was. As it turns out, I was asleep for it, but when I woke up, the staff was there to greet me, to let me know how everything was done. I see a lot of faces around here that I had seen that day. They always were coming to check on me. They were always coming to make sure I was as well. When I came to, you could feel some soreness. I don't know if I'd really describe it as pain. I don't know, self-proclaimed, I guess I have a high threshold for pain, but it felt nice. It wasn't the same pain that I went in with. This was pain from, I guess, from the robot or from Dr. Richards fixing everything, but it wasn't the same pain before. I knew I was good. I knew something had been fixed when I came to. So that was the day of, and I think it was probably about 1 o'clock that morning, post-surgery, when I finally stood on my own 2 feet and went to the bathroom. So whatever time you finished working on me, it was 1 o'clock when I was on my own 2 feet with no help, out of the hospital bed.
Great. Tell us about hospital discharge.
Hospital discharge, they made me get in a wheelchair against my will, and they took me down to my wife's forward fusion, and I stood up. I'm a big guy, 6'2", 270 pounds. That's a decent sized squat. This is the day after surgery. Got up, stood up out of the wheelchair on my own 2 feet, squatted down, got in the fusion, drove home. Very limited pain. Again, just soreness, not really pain to me.
So now, 11 days post-op. Tell me, you're having a lot of pain right now, aren't you?
No pain, sir. No pain, no narcotics. Between Dr. Richards and my wife, I'm still not allowed to do yard work, but that's okay. So I'll wait it out, but I feel like I could go out and do it right now.
It looks like he's got something under his shirt right in that area. Is that normal?
Still the binder.
Still?
So we put patients after this type of hernia surgery in a abdominal binder. That sort of holds everything in and allows the body to sort of heal. So there are some things that I haven't been able to control completely, okay? So one of the things that I cannot control is human biology, okay? It takes about 6 weeks for the body to lay down collagen, the glue that holds us together, to make this hernia repair that is strong now, but it's not as strong as it's going to be in about 4 more weeks. So that's why he's wearing the binder, and that's why he's not to do any yard work now for the next 6 weeks. But this is remarkable, okay? He has less pain after surgery. The concept by the lay public is that you have surgery, it's going to be painful, okay? And you're going to be laid up for weeks and months, and you're always going to have pain and scarring and everything else. That's not the reality with our robotic surgery right now. We're able to do things minimally invasively and reconstruct things so that we have super results. So let's talk about the finances. What does that mean for our system and everything else? He's going to be restored, okay? You've already heard that he's taking no narcotics now, okay? We got him out of the hospital in less than 24 hours, okay? Rather than staying in the hospital for a week or more. So the financial benefits to the patient, the insurance company, the hospital system is enormous because we have better results that are more, because the robot makes me a better surgeon. I see three-dimensionally, just like in open surgery. Laparoscopic surgery is unidimensional, okay? It's just a flat screen. But here I'm seeing binocular, so I have distant vision. My tremor is reduced. I'm able to articulate the little instruments and do the fine motions that allows us to reconstruct the abdominal wall through these small little incisions. And that means less pain, faster recuperation, better results, and we can help more people, okay? So this is a fantastic advance for, medicine. It's a fantastic advance for surgery, and it means that we can really help patients a lot more.
If you'd like to
Yes.
know, it is my third surgery down there. So 1 incision, 1 laparoscopic, and then the robotic. I'm here to tell you, the last one is the best.
How much did you have to pay him to allow you not to work?
My Ferrari's parked out front in the handicap zone.
I think Philip's wife wants to make a comment or a question.
No, I want to make a comment. When you see them,
Do you want us, can you stand up and come down here?
We have
Come
some
on.
microphones you can put
No,
on.
I'm good. So what you don't understand is my husband is 6'2", 270 pounds, 20 years military prior to that. That's his third surgery within 1.5 years. So he is not a person who will cry, but when the Dr. Richard checked him out, because he had to lay down and get up, he was in tears. That's how painful it was. And yesterday, no pain, no nothing, he was able to even to bend down, tie his shoe. And he has been without medication. He got surgery on the 24th. He has been without medication since Saturday. It's not that he is without medication since yesterday, today, whatnot. So you can see the picture that it didn't take that long of recovery. So I just want to say, I can definitely see the difference. I'm blessed that we were able to get Dr. Richards, and this hospital is amazing, so.
Yes.
I can say.
Her Ferrari's parked out front too, sir.
We also thank you for our service to our country.
Oh, thank you, sir. Thank you for fixing me and your team. I appreciate it.
There any other questions
What do I need to make an appointment?
today?
There we go.
After my river cruise.
Great to meet you.
Yes, ma'am. We can get you signed up. Ann can get you signed up. Okay.
Dr. Richards,
Yes, ma'am.
discuss hiatal hernia just a bit, please.
That's one of my other favorite operations. Yes, hiatal hernias are hernias through the diaphragm where the stomach slips up into the chest. And they can cause a variety of problems. They can be life-threatening problems, okay, in certain situations in which a large portion of the stomach slips up into the chest and then twists and strangulates or cuts off the blood supply. And those type of hiatal hernias are often seen in older patients, okay, that have these big hernias. And we do repair those, many of those, at USA Medical Center. The other type of hiatal hernia is a sliding hiatal hernia that's associated with heartburn and gastroesophageal reflux disease, okay? And we do those repairs on a routine basis. And oftentimes, one of the subjects for our previous Med School Cafes was about the magnetic beads that go around the esophagus in addition to hiatal hernia repair to augment the lower esophageal sphincter, the little muscle that prevents reflux of acid into the esophagus, causing heartburn. So in patients with severe heartburn and hiatal hernias, we'll do a laparoscopic robotic surgery to close the hiatal hernia and put the little magnetic beads around the esophagus to prevent reflexive acid. So yes, we do a lot of hiatal hernia repairs, and we do them also robotically in many instances.
And a hiatal hernia is not diagnosed by a bulge such as the others are. How are they diagnosed?
So the question is, how are hiatal hernias diagnosed? Okay, so typically they're diagnosed most of the time when patients present with severe heartburn and GERD, and the physician decides to do additional workup. They either do x-rays like a barium swallow where you drink the barium, and they do x-rays to diagnose the hiatal hernia, or oftentimes the gastroenterologist or the surgeon might perform outpatient endoscopy, where you bring you in, put you to sleep with medications, IV medications, and do an endoscopy where a lighted scope goes down into the esophagus, into the stomach, and are able to diagnose the degree of heartburn, esophagitis, inflammation of the esophagus, and whether or not you have a hiatal hernia, and whether or not you need some sort of surgical repair.
I had heard it said in the case of another relative that the only way to ascertain that you actually have a hiatal hernia is to catch it in the opening when the hernia actually opens. Does that make sense to you? Is it always open, or does it open and close by itself?
So in the case of a sliding hiatal hernia, the hernia does slide back and forth, just like abdominal wall hernias. So you might see a bulge, and the bulge goes back in. Okay, just like that. So the stomach slides up and down through the diaphragm, making it a sliding hiatal hernia. So there's some truth to that.
Okay, thank you.
Did a abdominal hernia due to surgery, if it doesn't hurt, should you just leave it alone even though it's quite large?
So the question is, should you leave an abdominal hernia alone even if it doesn't hurt? The only way I can answer that, it depends on the situation, okay? It depends on an evaluation by a physician to examine you and determine whether or not a specific hernia has to be repaired. In some instances, even though it's asymptomatic, we would recommend repair, okay? But most of the time, if it's asymptomatic, meaning that there are no specific symptoms, it really doesn't cause any problems, we would not fix it, generally speaking. As I tell the residents, it's hard to make the asymptomatic patient better.
Except if the looks of it is bad. Like I have to wear an abdominal band all the time because it's very large,
Okay.
very ugly.
Okay. Well, you've been a fantastic audience. I'd like to thank my co-presenter, Dr. Hunter. And have a great day.